you're in a place where you can turn on your camera, so much nicer to see a face than a name. So if you feel comfortable and you're decent, then just go ahead and turn on your camera, and we can have much more of a conversation that way. All right, guys. So I do want to be respectful of everybody's time. Look, Thursday afternoon, right after your semester is going to end. I just got home from work. I know you're hungry. You want to get to dinner if you haven't had it yet. So I do want to start. Honestly, what a great idea, guys, to do this. This is fantastic. This was not around when I was in med school. And I encourage you to make this interactive. Let's talk. Let's bounce off some questions back and forth. Sneha actually was with me at the hospital, last month, 2 weeks ago? It all rolls together. Last month at St. Joe's, one of our local teaching hospital. And look, man, the call is crazy. I mean, it's unpredictable, from nothing going on to absolute chaos. And I love it. The unpredictability of medicine is one of the things that you got to get ready for. So I want to, before we go into some specifics, I'll tell you a bit about my background, what I do, which I get myself into more things than I probably should, but I love doing that. But before that, just very quickly, shout out just some couple of areas where you guys are from, home-wise. I'm from South Texas. So what's the furthest place that we have from a participant?
I'm from New York.
New York, upstate or central or where?
From New York City, so Manhattan.
Yeah, oh, fantastic. Well, listen, I mean, your state's having a rough time right now. It's just like, all the other states, but look, I got great friends in Brooklyn, got great friends in Maimonides, at Albert Einstein's, fantastic state for medical education. But man, I sure hope we all turn the corner, because man, they're hurting right now with all the restrictions. Boston. Oh, Boston's a great place. Somebody put in the chat from Boston. It's actually Boston. What else we got? Yemen. Wait a minute. Wait, I just saw Yemen go by. Who's from Yemen? Y'all got to tell me who's from Yemen.
I am. I'm from Yemen.
Wow, you probably went for furthest. New York, sorry,
Yeah.
that was a good. But Yemen is a little bit further than you. So tell me, so Nima, how are things in Yemen right now? One, with the virus. Two, what's going on in your neck of the woods? You have family there?
Yeah, half my siblings are there. Regarding the virus, it's not. I don't see any cases there. It's lower than 10. That's what I heard. Otherwise, healthcare is horrible, but COVID, there's no COVID there.
No, man, I get you. You see, isn't that just like the world, right? I mean, you can't have it all. I mean, yeah. Access to maybe not that much care, but you don't get any COVID. The irony of life, guys. That's the way it is. So I enjoy learning from everybody. I'm from South Texas. I thought, I grew up, I thought everybody spoke Spanish, and then I went to Austin for undergrad, and man, different cultures. I had different foods for the first time. I was very sheltered when I grew up in South Texas. Man, I had sushi for the first time. I had Indian food, Thai food. I'm like, there's other cuisines out there when I got to undergrad. And then I went up a little bit further north to Dallas. I did my training at UT Southwestern, I had a blast there. I stayed there for training for OBGYN. Guys, I'm new to the Aggie family. I just got here in 2015. I was in the UT system for 20 years as faculty. So it goes to show, right? Never say never. I never would have thought that I would have joined A&M, but I got recruited by the med school and the hospital, and I'm glad for that decision. All right. Oh, we got somebody from Dubai. Listen, I was in Dubai in 2016. I was there for a week as visiting faculty. What an incredible city Dubai was. So what a testimony to this group. Do y'all see, if you can see your chat from New Mexico, Boston, Yemen, Dubai, fantastic. So this is how we all learn from each other. And this is the way medicine should be. This is how a medical team should look like. So I'm proud of you all for hanging in there. Look, right now, I want to share with you all several messages, but one of the first is, look how vital what you all have chosen is right now. I mean, every day for the last 8 days, we've gotten a notification from our teaching hospital, and we're at capacity. We don't have beds. And the problem is there's only so many faculties, only so many doctors and nurses to go around, only so much on the healthcare team. We need you guys. So, medicine has always been great. It's an honor to do that. It's a calling. But when people are sick, like they are now, I mean, what an amazing gift this is to take care of somebody. By the way, I'm getting over bronchitis. It is not COVID. I know what you're thinking. I just got swabbed today, and it is negative. It's literally, I think it's the stress of, we're pulling in a lot of hours. I'm on call again on the weekend, and I think it's my body trying to take me down a little bit. And so that's lesson one, guys. Look, I love what I do as OBGYN. Y'all start building healthy habits now, because it's very easy in this discipline, which is worth it, but very easy to lose sight of your own mental health and your own physical health, because you get so inundated with what you do. And I got to be honest, I'm still learning that, guys. I've been out 20 years, and my work life is balanced. I've just figured that out like the last year, to be able to step away and say no to some things. But you will always be in demand. You're always going to be needed, and that's a big burden. It's an honor, but it's also a big burden. So this is what's been in the news and in print lately is, man, our mental health and our ability to be normal. And it's okay to do that. Study hard. You got to kill that MCAT. You got to get your letters. But you know what else? That's part of life, man. That stuff will come and go. Your own physical health and mental well-being. We're seeing a lot of people, burn out because they don't have those tools. So I wanted to have open discussion in our time together about that, because this whole issue of resilience is something that we've never learned in med school, guys, and it's time to do it now. So let me put it to you in perspective real quick. I trained at a very historic training program for OBGYN, one of the best in the country. I mean, I'm looking back, I didn't realize how great it was. And I remember complaining about it, but Parkland Hospital's OBGYN's top 3 in the country. It was super hard, worked my tail off, and didn't recognize the value of it 2 years later. But I remember, guys, just listen to this, when I was an intern, and we worked 48-hour shifts, being tired at the end. And if you told somebody you were tired at a world-renowned hospital, here's what I was told. And I remember like yesterday, right, guys, I'm tired, I'm frustrated, I'm just beat. And I remember being told, all in a way to trying to build my character. Right? I remember my upper level residents telling me, man, that's weak. Don't tell people that. Right? Go wash your face and come back out, and you've got another 5 hours left. It was considered weakness to admit that you were tired. It was considered weakness to admit that you needed help. I trained with that. I mean, and so it was suppressed. I'm telling you guys, both as faculty here at this medical school and at another medical school where I used to be in Dallas, it's not like that anymore. And thank goodness for that. It's okay to say, yeah, I need somebody to tap me out. I need a break. I got to step away. That's finally, throughout the history of medicine, can you believe it? That's just now becoming the thing. And so I want to encourage you all that, again, study hard, never lose sight of your focus. It's all worth it. But it's also worth it. You've got to take care of yourself mentally and physically. Let me stop there for a quick minute from Suhas or anybody else and see if you have any questions or anything specifically want me to address. But I really couldn't let this time go without really encouraging you guys. Man, you guys got to be normal. If you're pre-med or you're pre-health, pre-nursing or whatever, I know it's mainly pre-med, you're already not normal. Y'all know that, right? I mean, it's hard to do this. You're wired differently for medicine because if you weren't, everybody would do it. There is a special wiring for us. It is a gift. It's an honor to do this. But for a long time, I felt like if I wasn't studying, right, I was wasting time. Guys, that's called just being normal. I encourage you to go watch a movie, go out with your friends. I mean, shut it off at times. That is healthy. And we're just learning to give that to ourselves as physicians to go, I'm not coming in for that extra shift, man. I'm just not. And that's finally acceptable. So else what you got for us? How do you want to open up to the questions? Anybody else?
I have a question.
Yes. Hey, listen.
Hi. I'm applying the next cycle. Like I took the MCAT and everything. I'm applying the next cycle. And I was wondering if like within your school, they are accepting like all virtual shadowing, because since COVID happened and everything, I've only been able to shadow like via Zoom and everything. I have research, I have everything. I'm just scared about the shadowing.
Yeah, listen, this is, so a couple of things for on your application cycle, guys. One, everybody looks different. Okay. I mean, some people are going to have some experience that others don't. Some people have published something or have contributed to a paper, others haven't. That's all right. It's great if you could put, if you could put on your CV, of course, some clinical time. That's not mandatory, but it does help. Like I said, Snehal came to our hospital right now, and so I take students here at BCS. But there's two issues right now. One is I've got a full student load because remember, I have medical students, some nursing students that rotate with me. I've got undergrads, some graduate students. And right now with the COVID issue going on, they're really trying to limit, because we had 5 people walking down the hallway, which normally is okay, but right now it is restricted. The hospital does do virtual shadowing. Shoot, they're doing virtual rounds for our medical students, trying to limit their entrance into the ICU. So listen, yes, virtual rounds is still acceptable if you can go into a location that way. It's not the same as direct being there in person, but I want to tell you that that's not the end all be all. Look for a good clinical paper that you could join on. Just talk to somebody. Do volunteer work. That volunteer work goes a long way. Things like this, being part of this kind of peer group on your CV shows that you have some kind of life outside of your studies. So I encourage you to be as involved as you can. Again, still be normal, but virtual shadowing has become a thing when before it just wasn't. But it does exist, knowing, of course, that there's some limitations. I can't take in a laptop for childbirth. I mean, it's just weird. So because of patient confidentiality. So there are things that you can do, but it's very discipline specific. And did you say that your boyfriend is an M1 here with us?
Oh, no, here in Miami, Florida. But I really enjoyed you saying like taking a break and everything, because he hasn't learned that and he burned out a lot.
Man, listen, you got to tell him. You got to tell him right now. Oddly enough, yesterday, guys, we did a symposium at our school, which was interprofessional education, and the title was Moral Injury and Resilience. All right. The idea is how we're so good at teaching pathophysiology and anatomy and pharmacology. We don't teach ourselves how to take care of ourselves. And man, I'm proud of him. He's M1. That's fantastic. You've got to balance it. Just because you study a lot doesn't mean you're going to get it any faster. I mean, it's about being efficient. Did y'all get that? Right? So just study, be efficient, and know that you can saturate your memory, and then you got to back off. I mean, your daggone hippocampus only takes so much. So it's okay. If you're not learning anymore, you've got to be able to shut that down. And it's just healthy. But I encourage you, look, if you have a way to do virtual shadowing, it's fantastic. Much easier to do in a clinic setting because you don't have the hospital regulations. Tougher to do at a hospital. But yes, it is possible.
So Dr. Chapa, we would like if you could just go into like your specialty, talk a little bit more like your journey, like how you got to OBGYN, your background, everything, and then we could go in from that. And then our team here will be moderating the chat, Dia, and we can do like a Q&A session.
Perfect.
And at the end, I think that would be a great way to approach it.
So there's only 2 camps for medicine, right? For medical students. The camp that they come from a long line of healthcare providers, or the camp where they're the first one. I mean, there's very little in the middle. I do not come from a line of physicians. I'm the first one to do so. So I didn't have anybody to tell me the good, bad, or the ugly about it. I just, to be honest, a lot of this was stemmed out of issues from my from my childhood. My father died when I was a kid. And it was a time when if you were a child, you could not go in to a cancer ward because of visitor restrictions. Okay, so my dad died when I was 12, going on 13. And at that time, the units were closed to anybody under 14. So I wasn't allowed to go in and see him. And the physicians that took care of it, what I remember was a very authoritative, very kind of cold and detached, because medicine was that, guys. And I felt that medicine just kind of didn't care. And so to be honest, I used that, be very transparent, guys, that anger towards medicine to say, I'm going to go in there and I'm going to show that you can do it different. So I'm telling you, I love science. I love that. I love the body and I love all that. That wasn't it. I went into medicine because I was pissed. I was pissed that somehow the discipline had let my dad die. Okay. So I use that and I feel that and poured that into my studies. And I'm thankful for what I did. I mean, again, I went to undergrad, I went to Texas. I applied to a handful of schools. I didn't have any money to apply and interview. And I remember, interviewing at Southwestern and UTMB and some of the other places in the state because I couldn't travel. I didn't have money to go visit other places. Short of it is I got into UT Southwestern, not knowing, anything about the school. Now, of course, I'm very thankful. It's a great school. But I got into that thinking that I was going to go do, some kind of oncology or surgical oncology or even orthopedics because I thought that was kind of neat. Man, I'll tell you, always go in with an open mind because I did my first general surgery rotation and I was like, man, that is not for me. And same thing with oncology. I just couldn't, I couldn't take the loss of people that were gravely sick. Is that weird? That's why I went into it. I couldn't do it. It was too much for me. And then I remember my first day at Parkland and they said, hey, Hector, go in there in that room and go push with the patient. So my question was, what the heck do I push? Push what? And they said, push with her. Push with her what? Like hold her legs back and push for her delivery. I said, oh, heck no, I'm not doing that. I'm like, surely you got somebody more qualified. No. And I remember clear as day that everyone started cracking up, not trying to be funny. I'm like, oh, man, surely they don't want me in there. But I was a third-year medical student. And I went with my intern and they coached me through it. And I delivered my first baby. And you know what? I mean, from that moment on, I mean, something changed. I'm like, this is incredible. I mean, people are generally healthy. If they do have like a cancer, usually they present at a time where intervention is possible. If they're sick, they were fixable. Do y'all get that? That was something usually there were something like we could get in, identify, and fix. And to me, versus like a lot of chronic care, like internal medicine or pulmonology, like, man, we can do something. Never thinking I was going to do OBGYN. So I applied. I stayed there for residency at Southwestern, and I loved it. Super busy. 80. What was it? It was like 80 to 100 deliveries a month or something. Was that what it was? Anyway, it was a large amount for our intern class. Super busy in addition to the GYN surgeries, and I've never looked back. I've always done both parts, guys. I'm in private practice and academic medicine. So I teach medical students, residents, and fellows, and I love it. I stay busy. I'm the OBGYN clerkship director here. I'm the director of interprofessional education. I'm one of 2 OBGYN physicians for Texas A&M, and I'm the women's health research lead for College of Medicine. So that's what I do. And I got a family and a little weenie dog that needs some time with me at times too. So I stay busy. I got students everywhere, as you know, witnessed when she came to the hospital. But I love it. Whatever you choose to do, guys, give it 100% of your attention when you're working, and then unplug. But I do encourage it. It's fantastic. I love what I do.
So everyone, you can put your questions in the chat, and Dia will read out the questions as you all message in the chat. Or you can speak up and say it as you feel.
Now I do have, so what does a typical day look like? Somebody put in the chat room. So listen, My typical day is very not typical. So for example, today I was in the clinic. So that's either from well care to a lot of procedures. Remember, OBGYN is procedure related. So we put quite a bit of Nexplanon for birth control, IUDs. We do a lot of biopsies in women's health to rule out pre-malignancies. Everyone thinks OBGYN is the babies, right? Oh, you deliver babies. Man, that's this much what I do. Then there's infertility, there's gynecology, there's GYN surgery, there's urogynecology. So it's a very varied discipline. And I find it interesting that it's one of the few disciplines that we can actually walk somebody through. Listen to this, guys. We can take care of somebody who's a teenager, right? Young female teenager, walk them through all their childbearing, walk them through menopause and into elderly care, right? Pediatrics has to give them up at 21. Internal medicine only sees you as an adult. But OBGYN can actually walk. I've got patients that are now, because I've been in it for a little while now, that I remember I took care of an issue for them for pediatric gynecology, and now they're coming back with their own family and pregnant. It's pretty neat to see that. So very few disciplines in medicine can walk a patient through all of that, and OBGYN allows us to do that. When I'm on call, my call is 24 hours and it's in the hospital. And so I'm in charge of our own patients in addition to the residents. We do deliveries, we do surgeries. We had a ruptured ectopic pregnancy last time I was on call. She almost died. This is a 17-year-old girl. So the ability, again, to get in there quickly, identify an issue. We opened the abdomen, took out the bleeding ectopic, tubal pregnancy, and she walked out of the hospital. That's an amazing honor, guys, to be able to do that. But there is no typical day, man. It's expect anything. And that is why I like OBGYN. It's very rarely mundane. So I don't go in, do the same thing, and then go, my day is, when I wake up in the morning and get to the office, I have no idea what's going to happen. And so that drives some people nuts. You have to have that personality to go, I have no idea if I'm going to get called in the next 30 minutes for some kind of crazy emergency or just stay in the office. And so if you like that variety and that quick pace, then OBGYN is something to consider. Somebody had mentioned about pediatric gynecology. And what is that? Listen, pediatric gynecology is cool, man. So that has things to do with usually with reproductive endocrinology. So little girls who don't get their period or don't have any breast development, there's a whole workup for that. Because some of these little girls, if there's no breast development, for example, guys, by age 13, and that needs an evaluation. And although it's rare, we have found, just like everybody else, that think about this, y'all listen to this. Sometimes we find that the little 13-year-old daughter that they've raised as a little daughter, because there's no secondary sex characteristics, one of the workups is to do a karyotype. Those are boys. So think about, that's testicular feminization or Schweier syndrome. There's whole conditions, and I've had two in 20 years, where your little girl hasn't developed breasts, because even though she's phenotypically looks like a female, genetically she's a male. And so we have to walk down that path. So pediatric gynecology is usually related to disorders of endocrine status, delayed puberty, imperfect hymens, or very young girls that have tumors. They can actually present with precocious puberty. So super interesting. Pediatric gynecology takes a lot of time because it's one of our most technical in the diagnostic process. Ooh, this is good. So let me have somebody answer this, see if they know. What does a midwife do? Anybody? What do y'all think? What's a midwife? By the way, midwives are usually women, but they can be men.
I believe midwives provide emotional and physical support for the mothers that are in labor, and also afterwards, after pregnancy, to avoid like trauma and stress afterwards.
Fantastic. So listen, guys, midwifery. First of all, I would not be here. No OBGYN worldwide would be here without midwives, because historically, the only people that attended deliveries were women who stood with the patient. That's midwives, to stand with. Okay, the word obstetrics comes from Latin, which means to stand in front of. That's where you get obstacle, because they would stand in front of the woman during childbirth. Okay, so obstetrics means to stand in front of or stand with. That's the midwife part. But there's two kinds of midwives, guys. So there's lay midwives, which our discipline has a little bit of an issue with, just because they don't have formal training. It's apprenticeship, and those are more like a doula, which is fantastic. Doulas do fantastic support. Doulas don't actually help with the delivery. They're there for emotional and physical support. And thank goodness for them. Those are doulas. Midwives actually help with the delivery. And there's lay midwife, which means they're not certified, and then certified midwives. Certified midwives are incredibly talented. We have a doctor of midwifery with us, Jennifer Light. Dr. Light, she's a doctor of midwifery, but she's not a physician. So midwives they're nurses, and then they go to midwife school, which is a certification. It's a very rigorous, they have to have so many cases. They do an internship. And so you can be a CN, certified nurse midwife, CNW. And so it's a whole certificate. You have to have a license, but you're not a physician. Now, our midwife helps us with surgery. So she helps us with C-sections, but she cannot be the surgeon. Do y'all get that? Right, so she has to be the assist. So put it to you this way, a midwife is what a CRNA is to an anesthesiologist, okay? So a CRNA is a certified nurse anesthetist. They're nurses who go for extra training and certification, and they put people to sleep. They do epidurals, they do nerve blocks, but they're not physicians. All right, so midwives, or we work hand in hand with our midwives. And I gotta tell you, for years, historically, there was this fight between we're the doctor and you're the midwife, and they're gonna do something alternative and we're gonna do something science-based. That's not how it is anymore. So midwives, welcome them. Our whole discipline for obstetrics was birthed out of midwifery, no pun intended. You all like that? Birthed out of that. But they do a great job. Certified nurse midwives, we have one that I worked with in Dallas, and I brought her to us into our hospital here. I stole her from Dallas. They are fantastic. They are a type of nurse practitioner. Okay, so PAs have their own school, PA school. NPs have their own training. Midwives, those are all called mid-levels, right? So you have a high level. I know that sounds tacky, guys, I'm sorry, but that's the way it is. A high level is a physician. Then you have mid-levels, which are also called physician extenders, NPs, PAs, midwives. And then you have first levels, which are nurses. And I know that seems terrible. I don't like that designation because, man, our nurses keep us out of trouble. And I don't like that designation of why it has to be this hierarchy, but it has to do with level of training, and somewhere somebody has, the ball has to stop somewhere, and that typically is a physician. All right. What else y'all got? So else you want to give us a question from our chat or open it up to verbal? Oh, let's see. I got a question here. What are your thoughts on natural childbirth versus scheduled C-section that aren't medically necessary? Listen, guys, y'all ready for a good discussion? So listen to this. When I trained, how crazy, medicine was paternalistic. Y'all get that, right? And guys, I'm not, this is no, I'm apolitical. But I'm just saying, before, medicine was very paternalistic, which means patients didn't have an opinion. It was what the physician said. I remember patients seeing them in the clinic as an intern, and patients saying, I want a C-section. I just want one. And the answer was, you would get a C-section. Listen to, I've had my faculty guys who wrote the book on obstetrics. It's Williams Obstetrics, okay? Wrote the textbook. I remember hearing them say, ma'am, you'll get a C-section when I say you get a C-section. Is that ugly or what? I mean, and I trained with that, and I remember going, man, that's some personality right there. And I never understood that, because it was, yeah, I will tell you when you can get to surgery. So primary C-sections that are called on demand wasn't a thing. We can no longer deny that. So if a patient wants a C-section and they have informed consent, the American College of OBGYN says that is part of patient autonomy. It actually is a violation of their ethics to say, no, I'm not going to do it. So if they want an informed consent, it's our job to give them the risks and benefits. And if I don't feel comfortable doing it, they have to respect my autonomy as well. But I have to then refer them to somebody who will do it. So the question was, how do I feel about it? My answer is, my opinion is that of the American College of OBGYN, which is if a patient wants a primary C-section and it's not driven by fear, because a bowling ball is going to come out of parts where they shouldn't have a bowling ball come out, and they're scared. But having a surgery isn't the answer either. So we can walk through that together and see, what are you afraid of pain? Yeah, well, C-section is not pain-free. Let's talk about that. What's your fear? I don't want to tear with a baby. Okay, well, let's talk about that. So if we can relay fears, and after all is said and done, they say, I still want a section, I'm totally okay with doing that. And we've done that. And that is allowed now as part of medical ethics. Oh man, this is some pretty medical stuff. Who's asking? I have a question. Jasmine, are you anything medical or any background in women's health? Or Jasmine asked about different positions for childbirth. That's a deep question, man, because we've learned something. So I'm curious if they have any kind of nursing background. Or here's a short answer. She's right. So for a long time, medicine was these poor women lie down and go ahead and leave you alone in labor. Well, we now know that's not physiologic. Labor actually goes better with called active positioning. So it's called a squat bar or lying on the side. We let them walk around. They have a little peanut ball that they get to sit on and helps the pelvis kind of shift. So we've learned a lot. And you know where that came from? Midwives. And for a long time, we looked at the midwives like, we have beds for that, man. What are the ladies bouncing on balls? Lay them down. They were right. So that's why you never criticize somebody else, because it all comes around and it works. So those are called the active positions of labor, and they do work. Man, guys, I want to get to, there's so much stuff on there. Ooh, stem cell. Fantastic. So we need a part 2, man, because these are good stuff. So somebody asked cord stem cells. Fantastic. It's great, and have cured a variety of childhood issues, including some leukemias. So you can do right now what's called umbilical cord banking. So baby delivers, you clamp the cord, and you cut off a segment, and then you sterilely collect some of the umbilical blood. That blood is totally potential. So it still has ability to change in the proper culture. It's expensive. There's no guarantee it's going to work, and it's not very regulated. So it's still on the very cutting edge, but it's definitely not universal. But if you look at CBR, a cord blood registry, have done some amazing things. But like everything else, some companies market that based on fear. Like, you don't want your kid to get cancer, do you? I mean, you're going to get your blood right. You're going to cord. Well, wait a minute. The science isn't all. It's there and it's good, but it's not going to cure everything. And that's where, like everything else, there's limitations, because right now it does cost a lot of monthly storage of that. I'm not saying that don't do it. I'm just saying it's like everything else. It can get taken out of hand and can be a placebo when some of the things aren't there. Eating the placenta, that's disgusting. And it is a thing. Please don't eat your placenta. How's that? What did you learn from Chapa? Don't eat your placenta. So check this out, guys. Don't do that. So about 10 years ago, who's from California? Come on, you got to say it. California. Okay, I love your state. It's fantastic, but it started in California. And the idea was, think about that. See, like everything else, a little bit of science makes sense. The placenta, guys, has loaded of estriol. right? So it's the pregnancy hormone outside of progesterone is a type of estrogen that's only found in pregnancy. It's estriol. Outside of pregnancy, you make estradiol. So the idea is, hey, if pregnancy depression, postpartum depression is because of a lack of hormones, then the placenta, pardon me, is full of good hormones. Let's go ahead and deep freeze it, and then cut it in little pills and ingest that to bring up the levels. So it sounds like a great idea. The problem is that it's not regulated, and there was a lot of bacterial contamination, and women have died from sepsis from that. So yes, it is a thing. The FDA, if you're bored after the end of this call, actually Google, just put in FDA warns of placental consumption. The FDA and the CDC actually have a warning to not do that. And if you feel that you have postpartum depression, there's true pharmacotherapy for that. But very well-meaning, not physicians, by the way, it was just a group of women who felt that maybe they could do that because they understood a little bit of the biology of it. But yeah, it is actually a very big health warning not to eat the placenta. And do patients ask for it? Yes. Last month we had a patient who asked for the placenta. It belongs to them. We asked, what are you going to do with it? And because it's considered a biohazard, they say we're going to take it home and eat it. And I said, no problem. I have to give you my ethical obligations to tell you not to do that. But I have to document what you're going to do with it because it's a body part. But it's yours. You do whatever you want to do with it. So it is still being done. Varnish, they said it tastes like chicken. So I don't know. It's just a joke. Just a joke. Everything tastes like chicken. Let's see. Oh yeah, man, I love that. Listen, so somebody asked, do you ever feel like you're not capable, like a fraud? What is that called? Somebody tell me what that is. There's a syndrome.
The imposter syndrome?
Man, look at you. Dear, you're killing it.
Thank you.
Okay, so let me tell you something, guys. Let me tell you. I've been out 20 years. I'm gonna be very honest. I have no pride, guys. I'm gonna tell you. Last call, which was Saturday, midnight, got a call for that ruptured ectopic 17. ER calls, hey, you got a lady down here, she's dying. You need to come down here and get her to the OR. No problem. In the elevator, imposter syndrome sets in. I've been out 20 years. I love what I do, and please, I'm not doing this as a braggadocio. I'm just trying to give you some relevance, how you shouldn't get rid of that. I got 42 publications that I'm thankful for. I love doing things like this. We've been able to speak around the world, including Dubai. Love it. And in that elevator at midnight by myself, I got this thing that, because your brain will talk to you, saying, you're not going to be able to do anything. You're going to get down there, you're going to freak out. You know that. You know she's super sick. Who are you going to call for help? Now remember, I'm the attending. I am the help. I'm going to have an intern with me. So I'm going to be very honest, guys. It's okay to recognize, and it's okay to be fearful. Because the first time I lose that, I think I'm done. Because the thing is to harness that and put it where it's not self-destructive, but it can actually motivate you. So I clear as day. I'm like, no, I can do this. I've done this before. She's getting blood. She's going to be fine. And if I run into trouble, I can call general surgery in case I can't see. Her whole abdomen was full of blood. So I can call somebody. But this whole thing of imposter syndrome, and if somebody tells you, oh yeah, you get rid of that, that's pretty scary. Because I've talked to many people in practice across disciplines. They're like, man, on a gunshot wound for trauma, who's very sick, and you'll see the attending surgeon, his hand, and the hand is doing a little shake. Because you're talking about somebody's life, guys. This girl was 17 and was dying. If you don't take that, if that doesn't move you to nerves, I think you need to quit. I mean, you should be afraid of that. And so do you ever feel like you're still not? Yeah, heck yeah. And it's okay. It's how to harness that voice that goes, you can't do it, and to answer back going, I can do it. And if I get stuck, I can ask for help. Because remember, guys, before you weren't allowed to. You had to do it and figure it out. We're not here to prove anything anymore, man. We're here to take care of people. And it's okay to say, I need help. That's okay. Epidurals, I've heard things like as feeling paralyzed. Okay, so epidurals are fantastic. In the chapter of Williams Obstetrics of OB, listen to this. I still remember the opening paragraph of that chapter says this. Very few, now listen, it's very powerful. Very few areas of medicine allow pain as okay and natural. Do y'all get that? Except for obstetrics. In other words, if you have a patient with a ruptured appy and they're screaming in pain, you don't go, oh, that's okay, honey. That's just part of the process. You're like, what are you talking about? Does that make sense? Right? You have a gunshot wound and they're in pain. Oh, don't worry, that's part of the process. But somehow pregnancy and labor, pain became acceptable. And so in that first chapter of obstetrics under pain management for the epidural, I love what it says is, hey, pain is a natural side effect of it, but it doesn't mean you have to accept it. So I'm a big fan of epidurals. They are fantastic. The fears of you getting paralyzed is real, but it's super, super rare. Those were usually done with bigger catheters. Those were in the history, in the heyday of anesthesia. The chance of getting paralyzed now is extremely small, barring some aberrant anatomy. But listen, night and day. Plus, when you get an epidural, it decreases stress hormones like cortisol and epinephrine, and actually helps you labor better. So it can actually help the labor process. Somebody put that, they love that perspective on pain management. That's cool. I appreciate that. Yeah, man, the only time in medicine, only field of medicine where pain is tolerated as normal is obstetrics. And I think that's wrong. How long does the stress go away for? Okay, I guess for that case, let me tell you. So this is probably, to be honest, where I got this whole resolving bronchitis. We finished that case in about an hour. You know, I went back to try to go to bed to, try to shake it off, and I couldn't. I mean, I said I'm wired. I mean, I got adrenaline is up, cortisol is up. And I think that that when your cortisol goes high, your vulnerability for infection drops, right? So you got to take care of yourself. And the AC and the filter in that car room, I think, is what gave me because I woke up that next morning after finally going down with this reactive airway. Now I'll tell you, it takes a while to come down from that. I had to get back to the car room and put water on my face. I had to turn on the TV. It's 2 a.m. at this time. And I should be in bed, but I couldn't. So it's man, you know what? Watching, hey, I have no pride. 2 a.m. watching some Simpsons is the best I could do to kind of take the edge off. And after 2 episodes of The Simpsons, I'm like, I gotta go to bed. And I had already come down. So it's okay to be normal. It's all right. People taking a gap year. I think 2 things. One, if you feel that your personality and or your mental or physical health needs that, you got to do it. So let me give a shout out to one of my undergrad students who's now in M1 with me, is Carly Hager. She shadowed me for a year. We have a paper published together. She took a gap year and she worked in the ER as a scribe in our hospital. Learned a bunch of medicine. So she wasn't sitting at home doing nothing. She stayed clinical. She probably knows more because she spent a year in the ER as a scribe than somebody else. And she applied and they asked her, what are you doing? She said, I'm working my tail off, 40 hours a week in the ER. So gap year is fine if that suits your needs, but you can't be inactive, right? So I want you to stay active. Now, some people take a gap year and do like a medical science master's, 1 year, master's of medical science. That's fine, but you gotta stay active. It shows that you're continuing, you're dedicated to education, and it's something that you'll never regret, either extra experience or extra degrees. But if you want to take a gap year, it does not look bad if you're active. Now, if you say I took a gap year and I worked at, I don't know, whatever, a local grocery store, that's fine. But it's not, how did you lose all of your pre-med information and knowledge? That's what they're afraid of. So as long as you stay clinical or stay something in that track, it's going to be fine. Oh, somebody's an ER scribe. Alyssa, she's an ER scribe. Fantastic. Man, you learn a lot. And it's a quick way to get over your fear of vomit and blood. Man, do a couple of shifts in the ER. My goodness. Ugh. It's not for me, man. I walk down there, do what I need to do, and say hi to everybody, and I'm out. The ER stresses me out. Medical research is great. Let's see. How do you manage the third stage of labor? Oh my gosh, it's so good. Guys, I really wish we had more time. Anyway, second stage of labor is obviously delivery. Third stage is from baby to the placenta. We give them medication called Pitocin, helps the uterus contract. And then if the placenta doesn't deliver by 20 minutes, that's pathological. That's called the delayed third stage. And usually we have to do some interventions. It risks bleeding and infection. So like everything else in labor, it's timed. So once that kid is out, you can't wait for 2 days waiting for the placenta. You can't take that home with you, or at least not inside your uterus. It's got to come out usually within 20 minutes. Average time is 3 to 5 minutes. Favorite part of being an OBGYN, I got to be honest. Look, man, you know what I really love is things like that. I'm an educator. I love doing medical education. OBGYN is just something I teach. But now I love what I do. But what really makes me happy is working with my med students, working with the fellows, the residents. I like that. I like that a lot. And to say that I can help mold future doctors. The OBGYN stuff it's just what I do, but man, teaching is much more, makes me much happier. Is it a female dominated field? For sure, man. It sure is. Listen, totally cyclical. Remember that OBGYNs, again, stole it from midwifery and women, and it was almost all male. It's weird. It was almost all male. And then 15 years ago, this tide changed. So now it's about 60 to 70% female, and the rest are male. How about that? So it's just something, it's just like urology. My counterpart for men's health is urology, right? And that's predominantly male driven, but female urologists, based on numbers and percentages and residencies, are coming up as well. Look, don't ever let a field kick you out, or you feel like you can't do that because it's dominated by something. Neurosurgery is another one, very male dominated. But Sasha Howell just graduated at our medical school last year, and she's doing neurosurgery at UAB, one of the top neurosurgery programs in the country, at University of Alabama, Birmingham. Almost all males. She's the only female in there. She's killing it. And she's going to be able to ride her own ticket because she's a female in neurosurgery from a great program. So don't ever let somebody tell you, oh, it's all women or whatever. That's what I got. Can you believe that? When I was going to go into OBGYN because that turn was coming on, my buddies from my class, my friends, like, oh man, you can't do that, man. Those are all women. I'm like, what? You're kidding me. Like, no, man, you got to be a surgeon. I am a surgeon. I'm just a pelvic surgeon. And I remember Vernell Johnson, great friend. I mean, he was my best man in our wedding. He's ER doc at UIC in Chicago. Man, he looked at me straight in the face and said, man, you can't do it. You can't do that. It's only for girls. What? Can you believe that? And again, and he's still a great friend, but there's some weird stuff out there. You do whatever you want to do. Doesn't matter who dominates the discipline. You go in there and you shake it up and you do the best that you can. Most common birth complication is probably gestational diabetes or high blood pressure. We've learned a lot. We've got a whole bunch of different therapeutics for it. Man, listen, OBGYN is great, and very few things are in the middle, guys. I'll leave you with this. Things are either totally well textbook and everybody's happy, or things go south like this. I mean, fast. You get a normal delivery who starts bleeding, she could die. She has in labor, her pressure goes up and has an eclamptic seizure, she can have a cerebral infarction and die. I mean, it's, again, I told you, it's very fast. So you're on this little cart on call, and your little cart can go up real quick and boom, can come down real fast. And if that's your personality, it's just not knowing. I mean, literally, it's not knowing what you're going to get. To me, that attracted me, because it literally is you're on this little high, this whole call, and then when you're done, boom, and then you finally can breathe and take it down. Studying abroad in med school, I think it's fantastic. Just got to make sure that one, it's US accredited. Second, a lot of those schools abroad are fifth pathway, like in the Bronx, they have a lot of fifth pathway programs. So if you're gonna do medical school abroad, it's fine. You just got to make sure that there's a good fifth pathway, which means that they share with the US, continental US training, because not all medical schools will take medical students who trained abroad. So not all medical schools abroad are treated the same. So you have to make sure that they have a long history of medical school acceptance in the States. And again, if they have a good fifth pathway. So what did y'all think? Did y'all have a good time with our, we want to be true to our time, y'all have fun? Hey guys, look, here's a free plug. Let's see if this works in March. And I'll have Sneha put this out if this works, COVID, it's day by day. But I'm very thankful in March, we have a rescheduled TED Talk that we're doing on mental resilience. It was supposed to have been done last year, but it canceled because of COVID. So I'm doing a TED Talk here at A&M on, it's called Mind Medicine, on how your thought life can determine your ultimate destruction or your ultimate success. And we'll send you a link. That way, at least we can keep sharing this message. Just remind me, Sneha, unless it cancels, that's through A&M, through TEDx. But you'll be getting the email from that as well because of the student body. But I'd love if this group could attend at least virtually. Guys, I had a great time. Said, do you have an Instagram? I have, if you, my Instagram is inactive because I was hacked. But if you go to Facebook and do Dr. Chapa OBGYN Pearls, we have a Facebook page. It's a lot of fun. Half of that stuff is ridiculous, just dumb stuff. And then the other half is, good women's health, anything leading in the news. We put on there. We also have our own podcast called Dr. Chapa Clinical Pearls, and he has all that, and they can get that to you. But I've had a great time. So thank you for doing this. I'm so proud of you guys. How much fun is this? You've got a great future ahead. It's so much fun, guys. I'm telling you, teachers, fantastic. The first responders, God bless them. Our police officers, the firefighter, fantastic. Our military, fantastic. The ability, guys, just remember this. When you get tired and don't think this is for you, your ability to take care of somebody who is sick or dying nobody else has that honor to do that. And I've had patients die, and I've held their hand as they've died, and I've seen people get better. You understand what a unique privilege that is to walk somebody when they're the people will give anything up. They'll give you everything they had for their health. And I'm not saying that in terms of a financial thing. I'm saying of the honor. Please don't ever lose sight of that. That what an awesome responsibility that is to take care of sick children, sick adults, elderly. Please keep that in your mind that we need good, caring doctors, because for a long time, medicine didn't do that. So it's worth your long time studying. We need you in the future. Okay, that's all I got. Proud of you guys.
Thank you, Dr. Chapa.
Thank you, Dr. Chapa. Thank you so
Guys,
much.
be on the lookout for that link too. I will send them that link for TED
Thank
in
you.
March unless it cancels, okay?
Sounds good.
Y'all have fun. If y'all need something, let me know.
Thank you.
Bye, guys.
Thank you all for attending. This recording will be uploaded onto our YouTube channel probably tomorrow or the day after, and we will post a link to the quiz soon. Thank y'all and have a good night.
Thank you.